Hi, I'm Dr. Joseph Witt-Doerring, and it is my pleasure to welcome Adele here. She is, I would say, kind of the mother when it comes to everything to do with antidepressant withdrawal. I sort of see her as the Heather Ashton of the antidepressant withdrawal community, and she has just massively contributed to the space by creating the Surviving Antidepressants Forum, which has been going on for quite some time now. And it is just a repository of everything anyone would ever want to know about safely coming off antidepressants. And so, Adele, thank you so much for agreeing to come here and allow me to learn from you and ask lots of questions.
Well, thank you, Joseph. That's very generous of you. Heather Ashton was a remarkable, brave, and incredibly tenacious person, and she's done a tremendous amount of work, incredibly, almost all by herself, put benzo withdrawal on the map. So I'm very honored by that comparison.
Mm-hmm.
I do think that I invented withdrawalology, so I will I'll claim that.
Yeah, and rightfully so. And I think that's a good place to start because I think the history of how the tapering guidelines emerged on the Surviving Antidepressant Forum is really interesting. So I was I was wondering if maybe first you could tell us you know, if you could boil it down simply, what is the best recommendation for people who want to taper off antidepressants, and then maybe explain to us how these recommendations evolved over time.
Sure. The I'll just go back a little bit in history.
Mm-hmm.
I came off of paroxetine in 2004 under medical supervision, and I developed withdrawal syndrome. And I it wasn't treated, and even though I had been seeing my doctors and asking them to help, but so I had protracted withdrawal, and so that was in about 2004, and I spent probably a year trying to get trying to seeking help from medical providers, and then at that I became very frustrated, and I ended up going to the web, as people will do, and I joined a support group, because at that time there were maybe a half a dozen or 10 independent websites having to do with different types of antidepressant withdrawal. And then, of course, there was Benzo Buddies, which has been around for, I think, since maybe 1998. So I joined a site that was called Paxil Progress, and that it had already been in existence for several years, and it already had probably about 20,000 members at that time. And it was pretty free form, and at that time it became clear that a lot of people were showing up who were being told to go off their antidepressant by cutting it in half, and then after a week or maybe a few days cutting it in half again, and then maybe just stopping there. So a lot of people were going off by what you could call it sort of like a half and half and half again method. And it didn't appear that it seems to produce withdrawal syndrome really well. So it seemed like it was not a good way to go off. So I guess we took a look at that, and just among ourselves thought that maybe it would be a better idea to taper at a smaller rate than, let's say, 50% or 25%. So kind of arbitrarily, we took 10%. So people were doing better with tapering at that small rate. But I think that maybe we might have we hadn't gone to an exponential reduction at that point. That was not and this was very informal. This was just, sort of like a very, people would join the site, and if they were lucky, somebody might come by and say, hey, why don't you try tapering by a smaller amount? I was a member of that site for quite a few years until about 2010 or 2011. And as these web communities will do, it was kind of disintegrating, and so I started my own site. But by that time, it seemed, for some reason, I had a curve in my mind where, that would be turns out to be a curve of exponential decay, meaning that the decrease would be proportionate across the curve, which means that if you're tapering, that the amount of reduction that you make keeps getting smaller the closer you get to zero.
And may I ask, was this derived just from your experience and experiences with others who found that as they got lower, it became harder? Was it mainly just coming from people just feeling this out?
Yeah, I think it pretty much it came from people feeling it out. So it really seemed as though, if you think of a helix, that it would be a curve that would be where you maintain a constant proportion, but in relation to the last dose, so that the steepness of the curve would be controlled.
Mm-hmm.
And this later on, Mark Horowitz illustrated it very well in a paper that was much more grounded in an understanding of receptor occupancy. I guess you could say that, yes, so that it was the hive mind at work, and I kind of gathered up those resources, and I was in the midst of withdrawal syndrome myself, and I really I couldn't do much except focus on the computer. So I wrote this up, and in a way that people could follow. I have a background in both instructional design and in technology, and writing. So I wrote it up. It became more widely adopted, and as it turned out, it was also a method that Heather Ashton had proposed, and there a few other people had been talking about. Some people were talking about 10% reductions, but they didn't specify that it was exponential, and others had talked about more exponential type of reductions. So there was some. So again, I think that just, like people from observation were converging on a similar idea.
Well, let me ask you about that, because, and this, I'm maybe a little bit embarrassed if I'm remembering this wrong, but I always felt like the exponential taper was something that more came out of the antidepressant space, because I've spent a lot of time poking around the Ashton manual, and for some reason, I see, I remember examples there of it being more linear. The cuts are really small, but it's like maybe if you're coming down from 40 of Valium, you're just knocking two milligrams off every time on the way down. But
yeah,
I mean, from your recollection, are there sections in the Ashton manual where she talked about, slowing it down towards the end? Or
yes, I think there are.
Okay.
I'm not I have to confess, I'm not the biggest expert on Heather Ashton, but
Okay.
I think that was one of the references I found, because I looked for references for this taper on my website. In my articles, I try to provide references where I can find them. So I had some I had some references. But Heather, in the antidepressant space, we don't do so much substitution. Heather Ashton was the substitution of diazepam for in benzodiazepine tapering was a key concept. But with antidepressants, we do more direct tapering. There's some people want to suggest that Prozac could be, or fluoxetine could be a substitute, the way that diazepam is a substitute for antidepressants, or rather for benzodiazepines. But there's something about that that switch to fluoxetine often doesn't quite work. So we've been tapering directly rather than the switch to fluoxetine is sort of a last resort.
Okay.
If you really cannot taper, which it's paroxetine is really hard. So unfortunately, it's something people might have to face.
So, and I think one of the key concepts, I guess, in the Ashton manual as well, is this idea of it's individual and it's flexible and it's led by the patient. And right. So, when I spend a lot of time, I guess, either in Cymbalta hurts worse or, surviving antidepressants, they do, it's like, 10% of the last dose, and you kind of follow that way, the whole way down. And this is like a nuance, it's interesting between the two communities in the benzo world. It may be more linear, but, heavily, emphasizing like, make sure that you never cut more than 10%, you never go any faster than 2 weeks between cuts so you can do it, and then just kind of adjust as you go. If you feel like, mild to moderate symptoms are fine, that's kind of why we're doing this, because we want our brain to readapt. But if you ever have severe symptoms, then you reinstate at the last dose, you wait till it resolves, and then you kind of come down. I think that would be the more, at least what I see more in the benzo world. I mean, is that similar in the antidepressant world as well, or is it more prescriptive? Like, you need to do, from the start, 10% cut, of the last dose, kind of the whole way down. Like, how do you see it kind of playing out, in the people that do this? Do they kind of stick closely to the method, or are they kind of going more flexibly?
Yeah, on surviving antidepressants, I have about a dozen really fine moderators working with me. Yeah. And we spend a lot of time in observation, and I think that I think that we're even more cautious because we advise 10% reductions per month. Mm-hmm. And the month is so you have that observation time for the drug washout, which is about 6 half-lives. I allow 6 half-lives for washout. And that means that the dosage change finally settles out to a steady state. So you can see the full effect of the dosage change after washout. And then we allow a couple of weeks after that for consolidation. So we want people to be, to be taking the next reduction from a really stable platform. Maybe that's overcautious, but we're real careful about that. And we spend a lot of time coaching people to watch for withdrawal symptoms. And if withdrawal symptoms occur within that period, and the washout is definitely sort of like a hazard period, that they would consider a smaller reduction the next time around. So we follow the same, I would say, the same kind of reduce and observe type of pattern. I don't think there's any other way to taper properly. You can't. There are some. There's some peer support groups that are pretty rigid about reductions, and they say, just keep on to the schedule despite any problems that you might have. But the thinking that we have is that, once your nervous system gets bruised from a reduction, you don't want to compound that with another bruise. So we advise people, if they get withdrawal symptoms, that they should not taper again until the withdrawal symptoms go away. So we're definitely very cautious about that.
Mm-hmm. And I guess, this may be a good segue to kind of, actually, sorry, one more thing I wanted to ask. In Mark Horowitz's paper, he talks about the the hyperbolic taper, and I think in one of the examples there, if you were doing it purely by SERT occupancy, which is the serotonin receptor occupancy, like I think the example might be something like citalopram. It's like you could go from like 60 to 40 or something like that, and you would only be doing like a 10% change at the level of the receptor. I think that's an interesting idea because that would almost be, at the higher doses, it's a lot, I guess it seems a lot more aggressive because you're dropping a higher milligram, but
Mhm.
but that's something that I don't actually see being practiced. I actually see people just kind of straight from the top, they're just 10% of the last cup, kind of the whole way down. What do you think about that difference there, with if you're going purely from like this hyperbolic model where you would be more aggressive at the top versus what is a more conservative model and what I see used more, which is the kind of the 10% of the last remaining dose the whole way down? Yeah.
Well, when he published his paper, and I saw that he was suggesting that the initial reduction would be, say, 50% or 25%, I kind of, went, ouch.
Mm-hmm.
Because the 50%, here's the thing, if from what I've seen, psychiatric drugs are generally dosed too high anyway. They're going over the top for receptor occupancy. So conceivably, if you're taking a high dose of a drug, your initial cut could be 50%, and you'd still be at maximum receptor occupancy, or close enough that it wouldn't make much difference. But the thing is that this is very individual. So we don't know what any individual's receptor occupancy state is when they start out. We're going to assume that it's somewhere up there, probably in the 80% or so, because it seems as though even small doses will have substantial receptor occupancy. For peer support in survivingantidepressants.org, we don't have the ability to prescribe, let's say, a rescue dose of benzodiazepine if people get into trouble. So we err on the side of caution, and since we can't figure out what anybody's receptor occupancy is, we say start with 10%. But 10% proportionately is if you're taking 100 milligrams, let's say sertraline or something, then that's 10 milligrams. So it's still a chunk of milligrams. It's not insignificant. And of course, it gets smaller and smaller as you go down. But it's possible that an initial 25% reduction would be tolerated, but you'd have to have people. You want to have and I would like to hand this over to medicine for sure, but you'd have to have the clinician paying really close attention to what happens after that 25% reduction. I think that 50% is really, like walking on the wild side. Yeah. But I feel more comfortable with the idea of a 25% reduction, but on survivingantidepressants.org, we're extra careful, and we say start with 10% and see how you feel about it.
If someone if someone was doing this taper, and let's say they're non-injured, so they haven't, they're on a stable dose, they don't have protracted withdrawal or post-acute withdrawal, and they want to come off, and they're doing the taper, and they said, I've been doing this for 6 months, and I'm haven't had any withdrawal symptoms, and they wanted to speed it up. Is there I guess is do you, I mean, do you ever think that something like that is okay if maybe they don't want to go down proportionally and they want to kind of, keep, I'm just going to, shave, let's say we're doing Zoloft or something like that, 100 milligrams of Zoloft. I'm going to keep on shaving off 5% at a time. It's like, do you see people wanting to rush it? Because definitely in my work, I see people wanting to rush it. I'll be doing these slow tapers with benzos, and the guy will say, I'm tolerating this fine. I want to be off as quickly as possible. What do you think, doc? Should I, and sometimes I don't know what to tell them. So I'd love to get your kind of thought on people when they're like, I don't want this to take, another, 12 to 18 months. Like, maybe I'll just keep on going at the same pace. What do you think about that? Because it's definitely a question I get asked all the time.
People do, they really hate the idea that it's going to have to be so slow. They hate it. And they are resistant to it. Miraculously, there are people who can just suddenly quit their drugs and have no problems. And their friends tell them this, like, I don't know what you're talking about. I just went off my, whatever, like citalopram, and I was fine. I don't know. Here's the thing is that once you break it, it's broken. It's, it's like, it's a scary thing. People don't realize how delicate the mechanism is. If somebody is tapering at 10%, Mark Horowitz actually has a method for this, which I think is really good, is that people need to track their withdrawal pattern. If you find, let's say, that you have, you get withdrawal symptoms 3 days after a reduction, and they're mild withdrawal symptoms, and they go away in a few days, we would call that, a successful reduction. And then you would, if you feel perfectly okay after another week, you might be ready for another reduction. But you have to allow that time for the observation period. That's the controlling factor, is that you want your observation period. And I would say, 6 half-lives is really the limit. So for most drugs, that's going to be, it's going to be a week for most antidepressants, because their half-life is around 24 hours. And then, you do want to allow a little extra time to see if there's any other fallout. So I would say that the minimum time is every 2 weeks. A reduction is every 2 weeks. Now, the problem is that if you don't already know, you're going to have to go more slowly to observe your withdrawal pattern at the beginning. So you have to do this very systematically. So you have to go through a few cycles to see if you have that very predictable type of withdrawal pattern, or maybe no withdrawal pattern at all, maybe no withdrawal symptoms. And then I would say you can start to compress the timeline. So rather than, let's say, a reduction every month, you might do it every 3 weeks to begin with, and see how that goes for a few cycles, and then every 2 weeks, and see how that goes. Now, the problem is that as you go lower, of course, the reductions become more perilous. So by that time, you might be in a 2-week reduction cycle, but it's not enough time for the withdrawal symptoms to appear. And then you might start compiling withdrawal upon withdrawal, because the cycles are too short. So if you get into a problem at that point, let's say after a couple attempts at that, I would say you're going too fast. And what we've found is that often, if people just stop tapering and stay at that one dose for an extended period, maybe a few months, that they have a better platform for continuing their taper. But you've got a warning signal. If you develop withdrawal symptoms, you've got a warning signal that you have to slow down.
Based on your response, I'm assuming that you would think it is preferable to speed up the duration, I guess, to shorten the duration between doses than to mess with the level that you're going down. Kind of keep that still like 10% of the last dose kind of pattern, or maybe I'm presuming. Yeah.
No, it could go either way. You could
Okay.
either shorten the interval, or you could make the reduction smaller. You could go either way. We have people who are doing
You
what's
mean make
called
the reduction greater than shorten the
no,
interval?
you
Okay.
make the reduction smaller and taper
Okay.
more often. So we
Okay.
have people who are, like, let's say, making 3% reductions every week.
I
So
see.
so rather than, let's say, so that amounts to about 12% per month. So it's not so it's a little faster than a 10% reduction per month, but it's possible that if they're tolerating it, that their nervous systems are recovering in that short amount of time from that small reduction. See, I'm thinking that what you want to do is you want to sneak off in a way that your nervous system doesn't even notice. So it's going to be individual according to the sensitivity of your nervous system. So if you can sneak off by just by like reducing a teeny tiny bit more often, then that could be as successful as let's say a 10% reduction with a larger interval.
That's a good point. I mean, I see. I like to think about that there are just like foundational principles in this, and really it's like listening to your body is the major one. You provide them the framework and, the recommendations, but then everyone's different. So some people, like you mentioned, they may be able to do drops every 2 weeks, and if they're tracking things systematically and they're tolerating, it's okay. But if that's not you and it's taking a month or 6 weeks, then you just need to listen to your body and do it that way.
Yeah,
Um,
yeah,
yeah.
yeah. But people are not used to this type of discipline. So some people take to it really well, and other people do not take to it well, and
Hmm.
they just kind of improvise as they go along. So yeah, so you have to listen to your body, and some people, they just start out with this attitude of I'm just going to power through it.
Mm.
So they're yeah, so they, a lot of people, like brain zaps, for instance, they'll say, well, I get brain zaps when I skip a dose, but it's no big deal. And then they think that, they're going to go off their drug really fast, and all they're going to have is brain zaps, and it's not a problem. In my opinion, brain zaps are a problem. I mean, they may not be painful, but they're a really abnormal neurological sign.
Hmm.
So it's I would take them seriously, and I think that one of the big errors that doctors have made in observing antidepressant withdrawal going back to the early 90s is that they didn't even see brain zaps. I mean, they didn't even record brain zaps for
Uh,
many years, and then later on, they just they just dismissed it as being a mild withdrawal symptom. And I don't think that any neurologist would say, oh, it's okay if my patient has brain zaps. It's a very peculiar symptom.
it is really peculiar, yeah, and I think that's good advice. I mean, yeah, that's not something you'd want to push through. You'd want to wait for that to resolve
Yeah,
before going any further. Because you're right, it could be I mean, it's a sign of neurotoxicity. There's something abnormal going on.
it's definitely I would it's like a signal flare coming up through your neurobiology, right?
Yeah. Back onto the subject of watching and waiting. One of the things that is I guess, really peculiar about the antidepressant withdrawal world is the delayed onset of symptoms. I I've heard of it with benzodiazepines, but to me, it almost seems more common with the antidepressants. And this is just anecdotal from my experience. And I work a lot with benzo people where the benzo injuries, I usually hear them like, I got rapid tapered, I was in acute withdrawal, and then, maybe for 2 weeks where I was miserable, and then it just never resolved. And the injury has kind of started from that rapid detox. But when I work with antidepressant folks, like I'll have someone taper down off Lexapro gradually. They'll have kind of some withdrawal symptoms for like 2 weeks. And then like 2 months later, 3 months later, they develop akathisia. I mean, the drug has been out of the body for several months at that time.
Mhm.
And that seems to be the most peculiar thing for me because I read it all the time, I see it all the time, and I just wanted to get your thoughts on that. Like, what is happening? Like, I mean, like what is happening with these really delayed withdrawal symptoms? And this is one of those areas where you may not know, but to me, I'd love to get just your conceptualization of this, of what people are saying about that phenomenon, because it's really unusual.
Well, I think that that your body is going to, it does its best to maintain homeostasis, and that it gradually slips out of homeostasis. So it's something that the probably occurred while the taper was going on, but the symptoms weren't noticeable. And then it's like a domino effect. So it slips out and finally loses significant balance, and then the symptoms are more severe and noticeable. I think that a lot of times when people go off of their their drugs in general, initially they have very mild symptoms that they interpret as something else. Like say, oh, I'm feeling, for instance, the flu, having a cold. I didn't sleep well because of stuff that's happening at work. So they'll. There are alternative explanations for very mild symptoms. And then if, let's say, they have a drink of alcohol, then something, or they take an antibiotic, then all of a sudden it just, it's like a fire starts, it becomes bigger and bigger. So it's like a little bit of disequilibrium, or a little bit of dysautonomia can gradually become a lot. And I don't know. We just don't know why this happens for some people, and we don't know what exactly what to do about that, other than depending on what the symptom pattern is, when the symptoms flare up, possibly trying a very low reinstatement of the drug, and or some other kind of, figure out some other way to deal with those symptoms. But it's, I mean, these drugs get into your nervous system, and they become a part of the structure. And when they're taken away, it's like, the scaffolding is gone, and maybe some kind of cracks have been appearing during the process, and then they just get bigger.
It's interesting. Yeah. I mean, this idea of equilibrium and homeostasis is interesting because I could foresee, that maybe you stop your last dose and, your brain actually has the capacity to still maintain an equilibrium, but maybe it's just trying really hard, that
Right.
it's full throttle trying to keep things balanced. But then, 2 months, 3 months later, it's too much, that it cannot cope with the changes anymore. And then it's not able to. And then you get this kind of toxic type reaction with akathisia emerging because things are so out of balance. And so I think that, I mean, that might be, I mean, that's the only way I could make sense of it at this time. But I'd like to ask you a little bit about reinstatement, because from my experience, that doesn't always work. You know, when once they've kind of gone into that toxicity and they've developed the akathisia, um, sometimes it works, sometimes it doesn't. Could you tell me about your experience, you know, working with people and reading stories about that? I mean, how frequently does reinstatement work? I mean, maybe if let's say they were coming down off Zoloft, I mean, what dose should they try and reinstate at? You know, 5 milligrams, 10, 25, 50? Like, how do you think through these things when you're kind of in that chaos?
Yeah, right. Um, I was going to comment earlier that Stuart Chipko used to phone me and all the time and talk about
Yeah.
this problem with delayed withdrawal showing up months and months after he's very carefully tapered somebody off. And he also used to call me up and say, "You're reinstating people at too low a dose." because
Yeah.
because what we do is, reinstatement can work surprisingly. And what we do is we tell people to try an extremely low test dose. And this perhaps, let's say, somebody's come off of, I don't know, 20 milligrams of duloxetine might be a milligram of duloxetine, or 10 beads of duloxetine, because that's the only way you can really titrate duloxetine. So we'll suggest this, and sometimes it does relieve the symptoms, and we also feel that it's not that big of a risk. So it's a small, very small test dose to see if somebody gets just a little bit better, then that's a good sign. And even with those the symptoms that you called akathisia, which I know I experienced surges of anxiety that were quite horrible. That the restoration of a very small amount of receptor occupancy, which is basically what you're doing with a very low dose, can restore it. It can be enough of a crutch that we do see withdrawal symptoms at least lessen in intensity. It's possible that from that point somebody might go up in dosage, after giving the test dose a good run, and sometimes the test dose is enough. The nervous system really wants to stabilize. Everything really wants to go back to factory settings. So sometimes just a little bit of a crutch is enough of a crutch. It's really quite remarkable, because we do pretty routinely advise a low dose reinstatement, although, it's not guaranteed, unfortunately, and that's really too bad.
And I'm trying to think, in that example you provided where you go back on 10 beads of duloxetine, I would imagine, you should, at least from a pharmacologic perspective, maybe you should expect to feel better that day. It should be really that quickly. But I mean, is that how it plays out, or do you usually recommend?
Sometimes it's immediate.
Okay.
Absolutely.
Okay.
It's pretty incredible.
Mm-hmm.
But again, we know that even, a tiny amount can give that receptor occupancy as a boost. It's not invisible.
Mm-hmm.
It gets in there. So, perhaps that's what it seems to be enough in some cases to stabilize people. And then they can stay on there for a while, and they're going to have to go off, bead by bead. It's going to be very gradual, but they handle that.
And I guess, let's say someone does reinstate on a low dose. If the symptoms don't go away, do you recommend going higher on the reinstatement? Like if it was 10 beads, maybe we need to go up to 20 beads. and wait a little bit? I mean, I know this is a very inexact science. I'm just, I mean, what do you see
Well,
people
it
doing?
depends on,
Yeah,
again, we
yeah.
have to, we ask people a lot of questions about how they feel. So if they feel a little bit better, but they reach a plateau, we'll say, okay, maybe add in another 5 beads.
Hmm.
Um, and then they see how they feel after that. So sometimes people will start with, let's say, 5 milligrams of sertraline as a reinstatement, but then find out eventually they have to go up to 25 or 50. But that's okay.
Yeah.
That's how we want to find out what works as the reinstatement. It's not a one size fits all thing. Now, the problem with jumping in with, let's say, a full dose is that, and again, this is something that comes out of my website, so I'm not sure. I'm saying that this is coming from an amateur scientist. So it appears that people become very, very sensitized when they have withdrawal symptoms, and they start reacting to caffeine and to all
Hmm.
kinds of relatively mild things. The problem with, let's say, giving somebody 50 milligrams of sertraline after they've gone off of 150 over 2 years is is what's called the kindling effect, where that dose might be so high for their sensitized nervous system that the nervous system also reacts in a way that you might see akathisia and all those other horrible.
Yes. Hmm.
So that's because of a dose that's too high. That's the kindling effect. And so that's another reason that we sneak up on it. We just, we don't want to, there's no point in triggering and starting at the top and risking kindling if you can start at the bottom and just gradually go up.
That makes a lot of sense. So it seems like the key principle is really listening to the person closely and just saying, how did this low dose make you feel? Was there anything better? I mean, you may very conservatively decide to go a little bit higher, but if they're
Mm.
not getting anything out of it, and then I guess you have to assess the really, I guess, the need to put them on a higher dose again and have to go through the long
Yeah.
withdrawal and potentially, destabilize them by exposing the nervous system to a higher dose of that medication that they have not seen for several months or maybe a year.
Right. Well,
Yeah.
there's an infinite amount of ticks that you can titrate to. But the rule of thumb that I use is that if the reinstatement helps them a little bit, then let's hold on that and see what happens. Sometimes people feel that they've intuitively reached a plateau of effect and they want to increase. Fine, let's try a little bit more. So they keep, they might go up a little bit more, and if they have the hang of listening to their bodies, it's really a good guide. If they have no effect, it may very well be. I mean, no effect is not terrible. No effect may mean that it's just not enough. So then we also will increase the dose slightly, and and keep going to see if we can get a good effect out of it. At a certain point, you just have to give up because maybe it's not going to work. But if they get a bad effect, you know that you're going in the wrong direction. So you can just back out of that. Again, so if you started at a low dose, it's a relatively low risk to just an unsuccessful experiment and just stop it.
And may I ask, from your experience, I guess observing people who have had this delayed onset, akathisia or the constellation of protracted withdrawal symptoms, is there any pattern there? When it emerges after that last dose? I mean, is it around the 2 month mark, the 6 month mark? I mean, and then also, like, how late have you seen it? Has it emerged like 12 months later? Could you share your experience just from anecdotes that you've heard about when this pops up, and maybe there's a more common time or that you
Well,
see?
yeah, okay, yeah, I have yeah. So the in the literature, when they say that withdrawal symptoms appear, like a few days after stopping the drug, of course, those in none of those observations were based on very gradual tapering.
Mm-hmm.
There's all of them were based on rather abrupt tapering. So you're that is in a few days means that that the nervous system has noticed that there's a big change, and that the domino effect probably occurred after the very last dose. So that probably started. That's a period where, again, in the literature, they've observed acute withdrawal, and that resolves, according to the literature, in a few weeks, which is, they forgot to continue observing to see what happened after that. So in the antidepressant literature, all of withdrawal is considered to be the symptoms of acute withdrawal, which across psychotropics, and this is in a paper by Lerner and Klein, who compared in 2019, who compared reported withdrawal symptoms from all kinds of psychotropics. It tends to be something like, they'll resolve in like a few weeks to a month and a half. 3 to 6 weeks is a acute withdrawal period. So that's what medicine knows about antidepressant withdrawal, coming from those abrupt discontinuations. So we see people tapering, and sometimes withdrawal symptoms will appear while they're tapering. So it's pretty clear that even a small reduction, since we have everybody reducing gradually, a small reduction might evoke withdrawal symptoms, and they will appear within a few days. So it appears that the nervous system will notice a drop in a few days.
Mm-hmm.
If somebody has been very gradually tapering and managing their taper in a way that they're not compounding withdrawal symptoms by tapering too fast, again, the washout period, I think, is a period where you may that's the highest risk period for seeing withdrawal symptoms, because they usually they appear while the level of drug is declining in the bloodstream, and that takes around 6 half-lives. It gets down to its lowest possible level. So we see people that happens. That does happen. We see people, and here's the thing: is that there's so many confounding factors, right? Because people go off their drugs and they feel pretty good, and then they might, just have a glass of wine with friends, and it's not like alcohol is the devil or anything, but even if you've been tapering very, very carefully, your nervous system might be in a very, hypothetically, this might be universal, that the person is in a sensitized state, and that even a glass of wine it might trigger a cascade of destabilization. Or they feel good, they go to the gym, they overdo it, or they go on a vacation, and the time change will do it, because they're not getting, their sleep pattern is disturbed. There's so many reasons why withdrawal symptoms might appear, even though it seems as though somebody has been very safely tapering. And sometimes, we do have people coming in saying, I don't know what happened. I went off of citalopram 8 months ago. I seemed fine for 8 months, but now I'm having these surges of anxiety that I've never had before. And that's a fairly typical withdrawal symptom. So taking them at their word, it seems as though perhaps, their sensitization was such that it extended over that long period of time.
It's
It just accumulated.
It's an interesting way to think about it. The differential, I guess, is one. It could just emerge because, let's say, for whatever reason, you're no longer able to compensate for the the residual changes, after you've come off the antidepressant, and it boils over to a point. But like you said, a lot of people have very sensitized nervous systems coming off these medications. And this is especially true with the benzodiazepines as well, where, I mean, you name it, they get every adverse reaction when they try new medications. Was talking about a patient who had Flagyl, which is, it's a common antibiotic that you use for bacterial overgrowth here. Normally benign, but it has this rare risk for neurotoxicity. And you better believe that they got it, and it really set them off. And what are the chances of that happening? And I see this story again and again, which is that the nervous system is very sensitive. It's a lot more vulnerable to side effects to medications, to things like caffeine, to things like alcohol, where, I mean, it can, it seems to be able to cause these flares or these toxic reactions afterwards. So I mean, I wonder what you think about this kind of recommendation. For the year after you come off the medication, don't ingest anything that has a psychoactive effect. Just consider that your brain is still kind of reforming itself.
Yeah, this is what we've seen coming out of thousands of observations on my website, is that antibiotics seem to be quite an irritant. And really very small amounts of alcohol and antibiotics are probably the biggest problems, or other drugs. People become very complacent, and they'll just, and they might even take another antidepressant, and there you go, kindling. So, or could be anything really. There's any neuroactive type of drug or supplement, St. John's wort. Any of these things can kick off this this hypersensitivity reaction, and I think that the hypersensitivity is something, Joseph, that medicine is completely unaware of these psychotropics sensitizing people in this way. This is, we're seeing this across all types of withdrawal among the benzo groups. It's just become it's something that we understand, but medicine is just doesn't understand this at all. This is not something that has, that's risen to recognition. When I wrote my paper, which is called something like "What I've Learned from Helping Thousands of People Go Off Antidepressants and Other Psychiatric Drugs," I had to reach into the multiple chemical sensitivity literature to find evidence of the sensitization. This sensitization, it involves repeated exposures to toxic chemicals. So sensitization, I think, is a reality, and I also think that the very common practice of switching people from one antidepressant to another, or one antipsychotic to another, or even one benzo to another, does cause a cumulative sensitization, where eventually, the clinician says, clinician finds that the drug isn't, quote, working, unquote. Well, it's not working because, you've got some kind of maybe low-grade kindling reaction, or the person feels nothing but adverse effects from the drug. So I think that the sensitization is a reality in the general prescription of psychiatric drugs and other psychotropics, right?
And I see this, like, when someone has a benzo injury, they often ends up getting dismissed as being like I guess, like having a conversion disorder, being delusional. Because, all the doctor sees is, oh, this person's complaining of all these symptoms. And then every time I give them a medication, they have a bad reaction. They must be, just anti-medication, they must be in their head. And they get put into this box, and they're having genuine adverse reactions to the meds. And, the doc's just saying, this is far too uncommon. They're just, yeah. And
Yeah,
yeah.
it's very predictable, right? And sometimes this happens all the time with the people on my site. They'll go back to their doctor, and their doctor will say, "Well, we have to treat this even more strenuously." So then they bring out higher doses and stronger drugs, and the results are not good. And the further you go down that road with one adverse reaction after another from sensitization, and it causes more sensitization, and it makes it a lot more difficult for the person to recover eventually.
Mm-hmm. Yeah, and I think I read your paper, and I'm trying to remember. I mean, did you talk about the alcohol literature? Because that's one of the areas where I've seen that, where they show that if people get put into acute alcohol withdrawal several times, the likelihood that they end up going and having seizures goes
Right.
higher, and that kind of
Right.
makes sense. It's like acute alcohol withdrawal is destabilizing the brain. There's less capacity to cope with it after repeated insults, and then ultimately they get the fatal seizure that can lead to the cardiorespiratory arrest and death.
Yes, right.
Yeah.
And yeah, and right. I think that I think I did delve into the addiction medicine literature for certain aspects of my paper. My editor, who was Mark Horowitz, made me drop a lot of my references, so I don't remember if they made it in or not. But yes,
Yeah.
I studied the alcohol addiction literature. The addiction medicine literature is the only place where there's been really an observation of protracted withdrawal or sensitization or kindling. Kindling, the kindling effect. We've got I think the references are from the alcohol literature and from benzo literature from Heather
Mm-hmm.
Ashton. But we got the psychotropics have a lot of commonalities, and they can all cause this. And one wonders exactly, like with, let's say, if someone is addicted to heroin, they try and kick the drug several times, and then they lose tolerance, because they've been off of it, and then they get another dose that's maybe too high, and that'll kill them because they've lost tolerance. And I wonder if maybe kindling is also involved in that, but kindling is not real well explained. So I might be going way out on a limb.
No, it makes sense. I mean, essentially, we're just talking about the cumulative effect of getting on multiple drugs, stopping them abruptly, and the toll that it takes on your brain, and how you may respond to chemicals in a very unpredictable way after
Yeah,
you've
yeah,
yeah. Mm-hmm.
yeah. If you think of humans evolved to tolerate a certain amount of toxins, and that's why we have the pharmacological principle of adaptation and tolerance. But repeated application is not really, repeated application of strong engineered drugs is not really something that we evolve with. And to explain it to the people on my side, I say that the nervous system isn't made out of rubber. I mean, when you think of it physically, it's this very delicate web of incredibly complicated, tiny little neurons, and it's very delicate, and we keep on bouncing drugs off of it as though it had an endless adaptability. It has some adaptability, but if you keep on disrupting it over and over again, it has a lot of work to do to patch itself up, which is why protracted withdrawal takes so long. So I think that we have a lot of complacency about the 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 elasticity of the nervous system. And I think Giovanni Fava once wrote something like, "It's amazing that our patients survive this type
Yeah.
of clinical care where they get switched all the time from drug to drug." And I do think that eventually it takes a toll. One of my theories is that a history of being switched from drug to drug is something that sets people up for difficulty and withdrawal. It has nothing to do with their genetics. It has to do with their history. So that even, like if they've been on, let's say, citalopram for the last 10 years, but the initial period they were switched from, among 8 other drugs, that they may be set up for difficulty and eventually going off.
Yeah. Pivoting a little bit to talk about ways to cope. In the benzo space where I have a lot of experience, there's often not a lot you can really do when someone is tapering and they have protracted withdrawal. The way I kind of think about it is, it's a lot of reassurance. It's a lot of reminding them that they're going to get better, and that seems to be the trajectory for the vast majority of people. And then, to the extent that they can, to kind of distract themselves and stay engaged in their life if they're able to. I guess I wanted to get your perspective. What have you learned about, in helping patients cope with these protracted withdrawal symptoms from antidepressants that helps them get through it? I'd love to hear your thoughts on that.
Well, it's a difficult reality for them because here they are going along innocently, living their lives, following their doctor's instructions, and then all of a sudden they're plunged into this strange world of peer support and not getting any understanding from their doctors, and they're very shocked. It's very disturbing to them, because I think we all assume that there's going to be a medical safety net for us if something really bad happens. And then they find out that there is no medical safety net other than what a few pioneering doctors like yourself have provided. So it's really hard for them. That's an existential shock for them. That's really difficult. And again, they're actually going to have sort of like be in the situation of a person with a chronic illness for a few years while they recover from this. That's just, we spend a lot of time counseling people about acceptance and relaxing and not expecting so much of yourself, and also engaging in activities that are going to help you, enjoy life as much as you can, and be healthy while your body takes that time to heal. It's very, very hard. And, sometimes I say to people, well, what happened is that, you didn't do anything wrong. Just an accident came out of the sky and hit you. But unfortunately, now you have to cope with it. You have to let your body wants to heal, your nervous system and your body want to heal, but you need to do what you can to assist it and not to get in the way. So I think that understanding that is really important, because people become very frantic and they go from doctor to doctor and they get all kinds of remedies, and some of them really backfire in a spectacular way, and they become more and more frustrated and disappointed and despairing that they're incurable. So what we do see is that most people are going to very, very gradually improve. They're going to very gradually recover from protracted withdrawal over several years. And it's very, very tough. It's so So that's I think one of the major functions of peer support is that, is that we advise people of this, and we normalize it, I guess you could say. It's like sorry that you're a member of the club. So
Yeah,
it's,
sure.
it's so and they usually generally, I would say, they are very relieved to find that other people have experienced the same thing, because they think, of course, that they are, like the worst case, and there's no hope for them. Nobody understands, so that they're relieved by some understanding. But I wish that we could do more. There's not a lot. It depends on, of course, what their symptom pattern is, what they're capable of. But in general, it's just the basic things that you do to improve your health. Eat vegetables,
Yeah,
eat
yeah.
fresh
Healthy
food.
lifestyle stuff. Yeah,
Yeah, and be sure to get a little exercise, as much as you can tolerate every day. Um, get some sunshine, enjoy your pets. It's tough. Okay, and in that context, and I think that this is important too for us to notice, is that it seems as though no matter how people go off of their drugs, whether they have protracted withdrawal or not, they tend to go through a period of what I call emotional anesthesia. And this is to differentiate it from emotional blunting, which is an adverse effect of psychiatric drugs while you're taking them. So after you go off, a lot of people really commonly feel this, just basic, they feel like they're not enjoying anything. A lot. Sometimes they'll say that they're depressed again, but it's really an absence of feeling rather than depression. And we have to be sure to differentiate that, because people very, very commonly will show up and say, I went off of my antidepressant and I don't know what's happened. I'm feeling, I'm depressed again. And we have to ask them questions, and it turns out to be this emotional anesthesia, which also extremely gradually goes away.
it's an interesting corollary. I've been doing a lot of interviews with people who have PSSD recently, and one of the things that they report a lot is that when they stop their medications, and along with the genital anesthesia and the sexual problems, they feel just like you described. Like it's almost that, and they say it's like something inside me kind of died. It's that
Yeah.
feeling of joy that I would have when I'd hug my son or a loved one. I don't have that anymore. I sit in the car without music on, even though music used to fill me with joy. It does nothing for me anymore. And
Right.
they describe that they've lost this, the sense of sensory pleasure,
Mhm.
that kind of feeling. And like you said, that seems to gradually improve over time for some of them. But it's interesting. Sometimes it occurs while they're on the drug, but a lot of the times, which is really curious, it's when they're coming off where things really appear. And that's
Mhm.
also a pattern with tardive dyskinesia, which from the antipsychotics, that sometimes it emerges on the drug, but a lot of the times it's when people are stopping them. That's when whatever is going on, they start getting the involuntary movements that tend to be permanent. So, I mean, that it's
Yeah.
interesting that you're seeing the same thing. In
Yeah. Well,
yeah,
yeah, that's a withdrawal symptom from the dopamine neurons being exposed. It's dopamine supersensitivity.
yeah,
But and we have, we also guide people off of antipsychotics, so we're real aware of that, and it's really scary. In the United States, people are being prescribed antipsychotics for sleep. Yeah, I mean, they're being exposed to very high risk drugs for no real good reason. And I have one of my site members developed tardive dyskinesia taking 25 milligrams of quetiapine for several years.
it's so
So
common. Yeah,
yeah, it's really terrible. I mean, she's just the sweetest person, and then very innocently is following her doctor's orders. And well, I hope it resolves. So, yeah, so PSSD does not always accompany this emotional anesthesia. The emotional anesthesia can exist without any sign of PSSD. So
Yeah.
it could also appear with PSSD. So we don't know anything about this stuff. I think that Giovanni Fava also, he wrote several papers about, are antidepressants making people worse? And I think he was circling around this this post-antidepressant lack of, narrowing of emotional range.
Do they call it tardive dysphoria? That's kind of what I've
Yeah,
heard.
yeah,
Or
the tardive dysphoria is one of
yeah,
the
yeah.
terms, but I think that I would say that, again, as an amateur scientist, we've gone a little further in differentiating it from uh, garden variety depression. It's different from garden variety depression.
Yep.
It's that I think that in the in the literature, those who have observed it have tend to talk about it as a depression, and it's different. It's really an absence of feeling.
Emotional anesthesia is a lovely way to put it.
Yeah,
I
yeah,
think,
and it's
yeah,
not anhedonia.
yeah,
It's really just like, there's nothing there, because when people are depressed, they might have anhedonia, but they like something, they like chocolate or they like their dog or something. But this is a blanket feeling where like nothing gets through to you. I experienced it myself for quite a while. So,
yeah.
I know it, and I was shocked. I just couldn't believe that, that my emotions had gone so flat.
Mhm. And another thing I wanted to ask you about is the pharmacologies, the pharmacology that people use during this. I know in my work with the benzo community, I mean, some people say that they use CBD or cannabis, and while it makes some people worse, it makes them better. But the other thing that I've seen also is, when I have people that have profound akathisia to the point where, they stop eating and they lose like 30 pounds in 2 weeks, and, their skin is burning. I've had to put people on fentanyl to stabilize them sometimes because they just waste away in front of my eyes. Have you seen similar things with people with that severe, like protracted withdrawal when they're burning and pacing, like that they need to go on like opiate medications for, I don't know, to keep them alive so they're not, they don't take their life or anything?
Well, I have had a few people show up who seem to have some kind of wasting condition, which we don't know anything about. So
Yeah.
it's hard to say what's going on there. But um, uh, people report akathisia. I have people who've gradually recovered from it. It sounds like you're seeing some really severe cases. I don't have any capability to prescribe, so I suspect that if they do show up on my website, they look around and we can't really say anything to them other than to be patient and let it go away.
Mm-hmm.
So it's interesting that you find that a heavy pain drug would help.
Yeah, I mean it's nothing curative. It's a symptomatic mask, if for for
Yeah,
people, they're in so much pain. They've
yeah,
completely
right.
exhausted all of their family resources. No one wants to watch them anymore because it's so distressing, and it's
Yeah,
just, yeah,
yeah. I guess you could say that in the extreme, that what you're looking at is like, like is a pain syndrome that is sort of firing on all cylinders. It's like it's just tearing through the body in every possible way that it can
yeah.
do that.
Okay. Um, yeah, I was kind of just pushed into that because I didn't know what to do. And eventually, the one case that I worked with, he was able to discontinue it. We did this kind of on-off cycle where we'd use a fentanyl patch for, they last 3 days. So 3 days during the week he would get it, and then the other 3 days he wouldn't. And then we'd started, and we did that for a month until the wave ended, and then he was able to discontinue it. But it was, I'm kind of just feeling things out as I go. Yeah.
Yeah, I think that again. I think if you it could be, this is, you know, I early on started looking at dysautonomia, and dysautonomia explains a lot of the symptoms. But nobody knows anything about treating dysautonomia, so it's not that helpful to call it dysautonomia. But it also might play a part in, let's say, fibromyalgia, where you have a hyperreactivity of pain receptors, theoretically. And it could be that if you, again, if you give the nervous system a little bit of a crutch, that it'll repair itself. I think it's really remarkable. I think that it's, you know, if you have faith in that, and if you can figure out what kind of a little crutch to give it, it can't be too big of a crutch, because you don't want to like discourage it from reconstruction. But if you find out some way to give it a little bit of support, that might be a way to encourage the recovery. And yeah, I mean, we're very much out on the bleeding edge here. So I'm interested to hear that you did you had success with your method, and really, you know, I whatever, you know, perhaps that few days, those short periods of fentanyl assisted this person's nervous system to re-regulate itself, which is, you know, like what a wonderful thing that is.
Yeah, I have no idea what happened. I mean, it could have just been a wave that ended on its own, and I just gently helped him tolerate it. I mean, but there's other things, like you said. I mean, what if just having that respite, you know, from, you know, this crazy signaling just firing and causing distress did something? I mean, it could just, I mean, maybe it's that as well. I'll let you know if I have more patients that end up doing this with.
Well, you know, you're bringing up a good point, because I think that what we're looking at is crazy signaling. And you could, and it could be coming out of the central nervous system, because things are just not matching up properly. And I think that that's you know, I know that there's a lot of people who have views about the hormonal aspects of PSSD, but it could be a centrally mediated dysautonomia. So, and I had PSSD too, by the way. So, you know, I had the full, you know, the full set of the symptoms. And I fortunately did recover, but it took quite a few years. But I think that, you know, if you envision it as this crazy firing, you know, maybe nerve cells firing at the wrong times, nerve cells, you know, firing in the wrong direction, nerve cells not firing when they should, you can get, you know, it's a way to visualize the dysregulation. In my case, I was, you know, I was fortunate to find a doctor who did treat me. After I've been looking for 4 or 5 years, the last minute I thought that I would kill myself, and I felt like I was plugged into an electric socket a lot of the time, all the time actually. I wasn't sleeping, and he treated me with minute doses of lamotrigine, and lamotrigine is an anti-epileptic. And its action is that it dampens the firing of nerve cells, and it worked. You know, I was only able to tolerate a tiny amount, so I think at most I was taking 1.5 milligrams in liquid form per day, and it calmed my nervous system enough so that over a few years it stabilized. It took a few years. It was really, and you know, and for most of that time I was still pretty much incapacitated. But it did very gradually resolve, and that was such a relief. I think that Guy Chouinard talks about using anti-epileptics for dopamine supersensitivity psychosis. He made some observations about, again, reducing the seeing it as sort of rampant nerve firing. And so the anti-epileptics is what they do. Now, the benzos are, as you know, an anti-epileptic drug. So, but two-edged sword, as they all are, actually. So
yeah, I mean, that's a lot of the things that I sometimes try with these benzo injuries when, before going to something like fentanyl. Why not try gabapentin or Lyrica? I mean, it doesn't work all the time. Sometimes we try, just like, these kind of these nerve stabilization therapies that are usually the anti-epileptic type treatments, like, sometimes very low dose Depakote, very low dose lithium. Verapamil is a cardiac drug that has membrane stabilizing effects for neurons, and it's used in migraines. I think all of these things are interesting things to try, but I've never found anything that seems to consistently work. It's like a crapshoot, really.
Right. Yeah. Some people with severe withdrawal symptom go into the hospital and they get antipsychotics, and that seems to work. Mm-hmm. So I don't think it's a good idea, but it seems to work. So it's high risk strategy. But it's interesting that you mentioned membranes, because I wanted to, we were talking about what we found to help withdrawal symptoms is that omega-3 fish oil is something that I think that the chronic fatigue community originally was, it was a remedy circulating in the chronic fatigue community, and the withdrawal community way back when also picked it up, but it does actually seem to help. And the omega-3 oils are they're part of the constitution of cell membranes, so they're important. Perhaps they assist in rebuilding the cell membranes.
I wanted to ask you if you could quickly comment on I guess the status of protracted withdrawal from antidepressants or post-acute. Actually, I'm going to ask you this first. In the benzo community, there is a shift towards calling protracted withdrawal bind, benzodiazepine-induced neurological dysfunction. And I guess the reason they're doing this is because protracted withdrawal gives the sense that once you develop the syndrome, you could reinstate the dose and it would go away, like it's a withdrawal phenomenon. But what they're seeing is that reinstatement doesn't, like, once you develop this condition, reinstatement doesn't really work. It's like a brain injury that needs to heal over time. So they're kind of pivoting to a new word called bind now. Is something similar? I mean, what do you call the constellation of symptoms? Has there been a similar interest in, maybe linking it more to neuronal damage than withdrawal? I guess I'd love your thoughts on that.
Good question, I guess. Well, okay, so, well, we're kind of at the dawn of withdrawalology. So first of all, what's known of withdrawal is a lot of it comes from addiction medicine literature, and they have their own biases. So there's actually a reluctance to say that people who have gone through, let's say, a detox program and come out with this constellation of symptoms have protective withdrawal. They're considered to need rehabilitation. They just skirt the issue of the biophysiological problem. So so I guess we can call it what we want. I mean, I think that to link it to the historical, to what's available in history, I'd call it protracted withdrawal. And I think that, again, I want to refer to Lerner and Klein from 2019. So they found this very similar syndromes across all psychotropics, including addictive psychotropics. So what we're looking at yeah, I have a tag in my citation manager for theories of everything. So what we're looking at is, I think, a very, there's a lot of commonality, and I think that we're looking at this extremely, well, a very modern situation where people are being exposed over and over again to engineered psychotropics, and they're coming out of this with some type of neurological effect. Now, I think that if you put the cells under a microscope, you might not see signs of injury, because a lot of the effects seem to be sent perhaps from radiating from the central nervous system, and I would like to propose that they might be problems of timing rather than actual injury. So you can have dysregulation without actual,
Anatomical damage to the neuron that you could see, right?
So it's hard to, I mean, if I use the word injury, which I do call it injury because people will understand it, I'm meaning more of a global, destabilization effect than an actual injury, like a cut or a break or something like that. I think that if we want to enlist neurology in looking at this, which would be a great idea, but lots of inertia against it, that they'd have a hard time calling it a neurological toxicity, because they don't see the signs of toxicity and they don't see the signs of injury. Now,
I guess what you're saying, I mean, it's like more of a maybe like dysfunction makes sense, because then that could incorporate that idea that you may not see physical changes at the neuronal level, but that the signaling is all messed up. They're not functioning well.
The signaling is off. With if you have serotonergic downregulation, those receptors are not getting the signals that they should get, or they get them they get them in a weakened form, or they get them in a sporadic form, or they just, and that goes downstream. So everything is, it's all interwoven. And one neuron is looking for particular signals from another neuron so it can do its work. And if it doesn't get those signals at the right time, in the right intensity, in the right flavor, it gets confused, and maybe it starts sending off bizarre signals. So,
and I would say that it's probably, I mean, to me at least, it seems like it'd be more than just down regulation as well, because there's these epigenetic changes. It may just be they just don't function normally. Whether there's more or whether there's less, they're just not reacting the way that they were supposed to. That kind of chemical change over time has now altered the receptor, the ability to the receptors to do what they were originally doing.
Well, yeah, and it's if you think of it as this very complex web, the way these interrelated systems repair themselves, it would have to be in patches, right? It can't fix itself altogether. It would have to, probably start at the edges where they start binding together and figuring out their signaling. It's a negotiation, and then it would have to eventually, so initially you have 1% that's reorganized, and then it gradually builds up until you get all of the, most of the percents organized. So it fixes itself in patches, and they don't necessarily talk to each other until later. That's the way I envision a very gradual recovery. But again, in our very modern way, or maybe postmodern way, we keep on slamming the nervous system with one drug after another. We did not evolve to get continual applications of these neurological chemicals.
Mm-hmm. Got a lot to think about. I'm mindful of the time now. I think we've been chatting for about an hour and 40 minutes, so.
Well, this has been so much fun. We should talk some more.
Well, I was just thinking, I would love to talk to you again about. I'm thinking a broader topic. I want to talk about the recognition of this risk. So I will catch up with you on email because I think that's one of the biggest things is at least in the benzo world, we now have protracted withdrawal recognized, in the labeling for all of the benzodiazepines. At least in the US, I imagine it's global or will be global soon. But
Mhm.
that's not the case for antidepressants, and I want to know why. And I think that would be a really fun topic to talk to you about.
We should talk about that. That'd be interesting.
Okay. Well, on that note, I want to thank you so much for lending me your time and I guess the audience as well, so we could learn from you. It's been a lot of fun on my side as well.
Thank you.
Okay. All right. I'll be in touch. Take
Bye
care.
bye.